Welcome to the Healthier Pregnancy presentation series. I'm here with Dr. Kate Menard from the University of North Carolina School of Medicine and Center for Maternal and Infant Health to discuss the Affordable Care Act covered preventive services for screening for depression. Thanks for taking the time today to provide more information about this really important topic.
Happy to be here.
We're going to be discussing the screening process, interventions, counseling, referral processes for depression, and the specifics to pre- and perinatal patients. So let's begin by discussing a little bit more about you and your background. So can you tell us more about that?
Sure. Well, so as you know, I work at the medical school at the University of North Carolina in Chapel Hill. I'm the vice chair for obstetrics, and I'm the division director for maternal fetal medicine. I'm also the recent past president of the Society for Maternal Fetal Medicine, which is our national organization that leads research and clinical practice, translation of clinical practice, and sharing best practices for our specialty and obstetrics in general. I have the privilege of working in an environment at UNC where we have a wonderfully collaborative relationship with the Department of Psychiatry, and have some world leaders in perinatal mood disorder there. So I think that kind of we've had the privilege of kind of bringing obstetrics and psychiatry and mood disorder concerns together in a very collaborative way in I think a fairly unique care model that actually includes a special and I think unique perinatal mood disorder unit within our hospital for women who need inpatient care, but we also have a really nice situation in the outpatient arena that I'm eager to tell people about.
That's great. So why do you think then, based on your very rich experience, it sounds like, that screening for depression is so important for pre- and perinatal patients?
Well, we know that depression in general is one of the leading causes of disability for women worldwide. It certainly affects families, it affects their work environment, and it affects their sense of well-being and their health in general. So I think it's an easy argument to make, and there's a good evidence base for screening in general for depression. I think, in my mind, it's particularly important in the perinatal population because we're not dealing just with one life. We're dealing with a family. We're dealing with two lives. If the woman's pregnant of a newborn that's going to have, is going to be impacted by mood. We know that infants born to a woman who is depressed or reared in that environment have developmental delays, cognitive delays that can impact them. And we also know that treatment, that those disabilities improve in a mom who's treated and is in remission. So screening, identifying, and then intervening impacts the lives of two and potentially the entire family.
Absolutely. So there's, a lot of impact that you can make by screening.
Exactly.
And how do you feel like the screening process works best? In your clinic and your program, what's your experience?
Well, there are a lot of ways to go about screening, and a number of validated tools for screening for depression, and particularly validated in the perinatal setting, either for use during pregnancy or in the postpartum period. There's really not a lot of evidence to say that one is that much more effective than the other. So I think it's prudent to kind of for providers to choose the one that seems to be most acceptable and most practical in their setting. There are simple tools and even just a 2-question tool that can introduce the conversation. And there are more detailed inventories of questions that can be useful to identify women at risk. In our practice, we use a tool that's called the Edinburgh Depression Scale. It's a 10-question survey or questionnaire that is self-administered by the patient if they're literate, and they answer the question kind of in advance of seeing the provider in our setting. It's been validated for use in the antepartum period. It's been validated for use in the postpartum period. It's been validated in different cultures. It's available in many languages, and I think a good source. But it's not the only choice. It happens to be the one that we're using.
And so that one is the patient fills it out. Are there times where it may be better for the clinician to ask those questions in your experience?
So I think if a patient's able to fill it out, kind of is literate and can read, I think that works very, very well.
Okay.
I think in other situations, if the clinic's not set up to have, the tool is it's a one-page tool that's kind of easy in the, just as a patient's preparing for their visit, to go through. If they have a confidential place where they can answer these questions, I find that women may be willing to put something down on paper that they may not be ready to say. So sometimes it works to have both pathways toward helping a woman disclose issues. But we, this particular form we use, and then our nurses review it and kind of score it for us in advance, and then come to the visit. It's efficient for the providers as well to have this done in advance, and the providers then review the score, what that means, and do a further assessment if needed.
Okay. So basically there's a system in place where the nurses help, everybody's part of the team, it sounds like, with the screening.
Which is really quite important. There are kind of different levels where a woman will interact with a number of different partners in the team, and we want to be able to, have everyone be prepared to serve, respond, that sort of thing, to things that she might bring up.
So, okay, they're taking this screening. What does a positive screen look like? How does a clinician know, okay, well, this is somebody that might need more help?
Okay, so a positive screen, this is a tool that's scored. So there are 10 questions.
Okay.
Each question can get anywhere from 0 to 3 points, depending on how she responds. Let me just, I'll give an example of a question or two, if that will be helpful.
Sure.
So for example, first question is, I've been able to laugh and see the funny side of things. And then there are 4 choices. And they're supposed to respond to their experience. They're instructed to respond to their experience within 7 days of filling this out. And the 4 choices would be not at all, definitely not so much, not quite so much as I always could. As I always could would be a 0. Not at all would be a 3. And then with 10 questions, we get a score. If the score is over 12, then we know that is highly predictive of a potential diagnosis for depression, minor or major depression, and definitely requires follow-up. We use, and some people use 10, but we use 10 to 12 being our intermediate area where we think it's important to perhaps take some extra time for counseling, delve a little bit more thoroughly into some issues, and ensure that a woman understands, what signs of depression to watch out for, and make ourselves very available to her should things evolve. And then less than that, if it's a 0 to 3, we do in that situation less than 10, we educate all women about mood disorders and the risk of peripartum depression, but those are women we're not quite as concerned about. But we still want that. But we take more time and emphasis on resources for those that are in that intermediate zone.
So that's very interesting that there's an education piece for everyone involved. Do you find that with certain women that have been through very stressful experiences in their life, maybe even traumatic events in their life, that they're more at risk pre and perinatally for depression?
Yeah, certainly. I think one of the things we always want to do when we apply a screening test is understand sort of what the prevalence of the condition is in the population. We know certain women are at higher risk for perinatal mood disorders, and those are if a woman has had an episode of depression or anxiety, or anxiety disorder, or potentially a post-traumatic stress disorder. Those are women who are at exceedingly high risk of peripartum depression. So we take that history course in the antepartum period to try to learn about that in advance. People with family history of mood disorder, if someone has a mother who was bipolar, that sort of thing, these are women who are at higher risk for peripartum depression or mood disorder as well. And And certainly, the traumatic events in a woman's life can lead to unrecognized depression too. So it's not always apparent in advance of screening. One of the beauty of screening tests is that you're not just taking a history and finding somebody happened to them before, we're potentially uncovering the first. And it's very reasonable to think that that's going to be uncovered more frequently in women who have had trauma in the past.
Okay. So when you do uncover some sort of depression, then what next for the patient? Where do you refer them? How does that work?
So I think it's important if and depending on the questions, if they score higher or score in the area where they're reporting any kind of concern about suicide or self-harm, to take immediate action. If we're concerned at all about, ask a series of questions about self-harm for sure, to be sure that to be certain that they're in a safe place. If they deny that and you're comfortable with that, then I think the urgency for immediate care is less, but we can certainly, initiate some sort of treatment and referral. If there's urgency, then in our system we have, it's really wonderful that we have a psychiatry resources that see patients right in our OB clinic, right in obstetric clinic.
Wow.
So a woman, which does a lot of things. First, it makes that provider very, very familiar and available to us. We all know each other by our first name. It's really, she's just part of the team.
That's nice.
There's nothing, call so-and-so, fill in the blank on her name, and she'll be able to guide. So it's really front of mind for all of our providers that this service is needed and available, the value of the service is needed and available. Also having it immediately right there in the clinic removes some of the stigma that people might see as, oh, I'm going to go see the psychiatrist or the psychiatric nurse.
Okay.
They might not want to go to the psychiatrist or the
and that
psychiatric
person
nurse.
kind of comes to them? Is that how it works? Or
the office is right in our clinic.
Wow.
Yeah, so that it's just next door. I just somebody next door I'd like you to talk to, and it makes it really of course schedules don't always allow you have to triage a bit because schedules don't always allow you to have everyone be seen immediately, but even just having it in that same location, team, we think makes a big difference.
Yeah, it sounds like it's very collaborative.
Yeah, it definitely is. So depending on severity, but if we need immediate studies, we have crisis resources, emergency room, crisis center, but if it's, and many of our providers become quite comfortable initiating treatment. Not so much psychotherapy, that's not our role as obstetricians, but initiating a more thorough assessment, at least getting close to an appropriate diagnosis of major or perhaps more minor baby blues, and differentiating those three.
Okay.
And certainly our providers, most are comfortable with initiating pharmacotherapy if needed.
Okay.
And then with follow-up for psychotherapy or for a visit with our psychiatric colleagues, or simply follow it with us if the psychotherapy doesn't seem to be acceptable or necessary. But the collaborative approach makes it all so much more comfortable for the providers and for the patients, I think.
Yeah, it definitely sounds like it. What do you think are the major obstacles to kind of putting in depression screenings? Are there difficulty with follow-up? Well, although in your setting it sounds like maybe that's not as much of an issue. Right. I don't know. I mean, what are the obstacles? Are there any? There
are plenty. I have in our setting. We're exceedingly fortunate to have a setup that we do, but even there are some obstacles. But I have responsibility for a lot of statewide programs in North Carolina. I'm the lead physician for what we call our pregnancy medical home, which serves the Medicaid population statewide. So I hear, and have my finger a bit on the pulse of different practice settings and resources that may or may not be available at different places. I think one of the biggest barriers is having to screening is having the providers having the confidence that there's resources available to them for treatment and referral.
Okay.
the more resources you have available to you for treatment and referral, the easier it is to go after asking those questions, knowing you're not going to be kind of left in the lurch.
Sure.
And the other thing is, with more resources you have, if you're working with those individuals, you become more comfortable. I become more comfortable even beginning treatment, knowing that I'm not on my own. I've learned a lot from that colleague or colleagues that are around doing this care, and we're more prepared to even initiate, and learn, treatment on our own. So I think statewide, or nationwide, really, statewide, the more we can have educated mental health professionals geographically distributed and interacting with primary care providers, the better off we'll be. But those resources really don't exist everywhere.
Well, and so what advice do you have for overcoming those barriers for certain systems that may be struggling with that, of where do we, how do we create this sort of seamless team that you're describing? Any suggestions? So,
how often can we fall back on technology? One of the dreams of, not dreams, I'd say one of the realities of our team is doing a lot of education in and around this area, and is willing to extend themselves to help educate others that might be able to assist with developing collaborative teams.
Okay.
It's sort of, train, practice, but train the trainers sort of models, I think, that'll help disseminate and implement to a greater extent. We're doing within the pregnancy medical home in North Carolina, we have physician leads at the various networks who we collaborate on clinical pathways and developing those pathways, and then teaching our care managers that are involved in the content of that and that sort of thing. We're trying to work more completely to disseminate that work. The pregnancy medical home's focus by charge has been preterm birth prevention, but there's more data coming out that depression is a risk factor for preterm birth too. So we can fold it into so many areas of good health that we take every opportunity we can to do that.
Yeah. Are there any other either take-home points or other things that you feel like your healthcare system does to support the needs of pre and perinatal patients?
I think I've hit on most of the main points. We certainly build it into our education model too. We educate many trainees and residents and fellows and medical students, and kind of making this something that they become quite comfortable with, I think, is another goal that I'd hope other schools would work toward. But I think the key is to recognize that it's an issue, have a screening program in place, and just that in and of itself elevates, keeps it front of mind, and then have if it puts systems in place to have the resources for support for the providers, ideally located right, kind of within the care team, and not sort of out there or over there.
Okay. So education, screening, and collaboration. Any other take-home points? Or?
That's my points.
Great. Thank you so much for talking with us. I think you've done a great job in explaining all of this, and we really appreciate you joining us today.
My pleasure.
Thank you.